Okay, I think we've reached a lull in the meeting room, in the waiting room. Good evening, everyone. My name is Laura Miles, and I'm the U.S. Sales Leader for Genomind. I wanted to thank you all for joining us tonight. We have an oversold, fantastic crowd this evening. We will have just about 200 attendees tonight, so I wanted to thank you all for spending time with us tonight, for getting here early, for waiting in the waiting room, and for waiting patiently as we got started. Tonight's topic is the Genomind Mental Health 360. We're going to explain what that means. We're going to take a deep dive into our core flagship product, Genomind Professional PGx, and also introduce you to our newest kid on the block, the Mental Health Map. You can thank your sales representatives for the dinner, which I hope arrived on time and is delicious. So some logistics before we get started. I am recording this presentation so that you can review it again at your leisure on another evening or daytime or the weekend and share it with your colleagues. A copy of the presentation will be sent out to all attendees after tomorrow. You'll get a PowerPoint presentation from your sales representative. I am going to be muting everyone during the presentation so that Drs. Van Dorn and Dowd don't have any background noise and they're not distracted by kids and dogs and all the fun things that are happening in our lives. At the bottom of the screen, you'll see a couple of buttons. One is the chat. We will have an active chat going throughout the entire presentation. In addition to myself and some of my sales peers, we have some very talented medical science liaisons on staff to answer your deep and complicated clinical questions, which are over my pay grade. So feel free to ask any chat questions along the way. At the end of the presentation, we will have 15 minutes of live Q&A and cover off any questions that we didn't cover during the presentation. You will also note, as I mentioned, that you are muted, but at the end of the presentation, you'll see at the bottom, or you can click on your little box and see the three dots and you can unmute yourself. If you have any technical issues, to the extent that you're able to let us know, please put that in the chat. We'll try and resolve any audio or video questions. So with that, let me introduce our two speakers tonight. Let a couple more into the meeting room. First up is my wonderful colleague, Dr. Dan Dowd. He is the Vice President of Medical Affairs at Genomind. He is overseeing our medical affairs team, the medical science liaisons, and all the clinical support for the organization. Dr. Dowd received his PharmD degree from Rutgers University, and he taught the advanced pharmacology course at the CUNY system. Dan Dowd is very busy, and he also publishes a lot on the implementation of pharmacogenomics and is also a very active member in CPIC, which he'll tell you about later on. He is very involved in the development of our Genomind drug interaction tool, the GDIG tool, which we'll also share with you tonight. We have an exciting enhancement coming up in Q1. And of course, he is very involved in the development of the PGx product. You can see here some links to some of his published articles. Our other presenter is Dr. Daniel Van Dorn, also a PharmD. He is our lead scientist and senior medical liaison. If you've ever had a consult with the Mental Health Map, you've probably spoken to Dr. Van Dorn. He was very instrumental in the development and architecture of this new and exciting product for us, and also its predecessor, Mindful DNA. Dr. Van Dorn received his PharmD degree from Temple and also worked in a variety of clinical settings and also in the armed forces, and we want to thank him for his service. He also is an avid publisher, and it is often asked to guest lecture at many institutions, including the Perelman School of Medicine. So I think you'll be very intrigued and delighted by their presentation. They are certainly experts in this topic and have quite a depth of knowledge. So with that, I will turn it over to I will not turn it over. I'm going to tell you a little bit about Genomind. So this gentleman here is Dr. Ronald Dezorts, the founder of Genomind. Very sadly, Dr. Dezorts passed recently of COVID. However, he is the founder of Genomind and several other companies. And I had the privilege to work with him for over 10 years. His just perennial positivity was part of our culture and really set the tone for the vision of Genomind. We are based in King of Prussia, Pennsylvania, and we are 100 employees strong and growing. To date, we have tested over 250,000 patients with our core product, Pharmacogenomic PGx test, and have over 10,000 clinicians who have used our test. Currently, we are available in all 50 states and in 30 countries. And with that, I believe I'll turn it over to Dr. Van Dorn to kick it off.
Well, I'll take that. I'll take the lead on this one, Laura. Laura's being a little modest, by the way. She forgot to mention she was the #1 Genomind employee. So congratulations to her. We're about 100 strong right now. Laura's been with us since day one. So employee numero uno. Congrats, Laura.
Thank you.
So I'm Dan Dowd. Myself and Dr. Van Dorn will tag team this presentation. Dan has his hands in everything that we do as a company, but he really is the brains behind the mental health map. So he's going to spend most of the time talking about our new baby, which is mental health map. I'll spend most of my time talking about our platform of services and then focusing a little bit more on our pharmacogenetic test and also the software that we developed to supplement that pharmacogenetic test. And so that's our agenda for tonight. Like Laura said, we're going to do our best to answer as many live questions as we can at the end of this. But with 200 people, that might get a little unwieldy, so we'll see how it goes. All right, so here's our disclaimer. I'll allow everyone to read that on their own, but if you want the Cliff Notes version of the disclaimer, we will very likely talk about some medications that are used off-label. If you're okay with that, then please join us for the ride. All right, now we just went through an election cycle. We'd like you to do one more vote for us because we want to test out our new polling system that we've built into Zoom here. So we're going to launch the poll. The context of this poll is to decide whether or not Dr. Van Dorn looks more like Stone Cold Steve Austin or whether your own Dr. Dan Dowd looks like Christopher from The Sopranos. So if everybody would be kind enough to vote, I think this is an important topic. I think we need to have closure on this. So Laura, if you could launch the poll.
And choose wisely because there's a lunch writing on this.
That's right, yes. Assume Dan has his glasses off as you're making.
No. They don't need, don't try to sway the vote. Just let them.
You're right. I'll shut up and let it take its course. So please choose wisely.
Dan, can you say bada bing real quickly for me?
No, absolutely not. Well, I don't even know what was Stone Cold's catchphrase.
It had something to do with drinking a beer, I believe.
How are we doing with the votes, Laura?
I'm going to let it get to 90 in just a second here.
Okay.
90%.
You know what? 2 for 2, Dan. Good for you. So that's it. I owe Dan lunch. This is the second time we've run this poll, and I've lost every time. Or maybe I won. I don't know how to interpret this. But anyway, thanks for voting. Polling works. We'll have another poll, maybe 1 or 2 polls as throughout the presentation. We wanted to test drive this, and so far, so good. So let's talk a little bit about something that everyone is familiar with on this call. This slide is probably preaching to the choir here, talking about some of the statistics involved with mental health. So we're not going to go over each one of these individually. You're all familiar with this. Things like youth depression have increased over the last 6 years, and it's increased even further in the world of COVID. I think it's a pretty shocking statistic if you look in the lower right-hand quarter that there's 10 million adults that have seriously thought about suicide in the U.S. You've all seen these numbers. You're all familiar with these numbers. What I would like to do is take a bit of a deeper dive into some of the some of the gaps that are in mental health care that are contributing to some of these higher numbers. And we've identified, 5 gaps in mental health care that we are either trying to develop tools or partner with companies to help minimize some of these gaps. And, I've been with the company for about 6 years, Dan for about 3 or 4 years. And these are the gaps that we've come across most commonly in our time here. So for starters, there tends to be a lack of measurement-based care within mental health. Out of all the disciplines, it's still not standard of care to routinely measure our patients every time we see them. We've partnered with a company named NeuroFlow to try to bridge that gap and increase the amount of measurement-based care, so that both the patient and the provider have access to this measurement-based care along a continuum. We think as a company there's a failure of our current diagnostic criteria. So the DSM-5, leaves a little to be desired. Part of what Dan will talk about as he presents the mental health map is the RDoC approach to mental health diagnoses. And RDoC is research domain criteria. It's a paradigm sponsored by the NIMH. And Dan will talk a little bit about how we use this RDoC principle to build the mental health map platform. Early intervention. So if you look at the STAR-D trial and you look at rates of remission for depression, they're right around 30% with a first-line treatment. The problem is by time mental health care providers are seeing patients, patients are usually in like a grade 3 or grade 4. Think of mental health patients or psychiatry patients along a grading spectrum, the same way they do in oncology. And we usually see them by the time they're at 3 or 4. Part of what we did with mental health map is to catch them in stages 1 and stages 2, and then reserve the other tools, the pharmacogenetic tools and the drug-drug interaction tools for the later stages. The supply of mental health providers, unfortunately, is still not enough to meet demand. To help with that, we've developed some of these software tools that we'll talk about to help primary care providers and other providers that are not psychiatrists, not psychiatric nurse practitioners, not psychologists, may not have the mental health training that everyone on this call does, but we can provide tools to help them feel more comfortable expanding their range of medications. Lastly, we noticed that providers often have narrow treatment algorithms, and we want to, again, design tools to help them be more comfortable expanding their range of treatments. So, there's still many providers who are comfortable with SSRIs for depression, maybe some SNRIs and some stimulants for ADHD, and that's it. And they're really not comfortable, and they don't have the tools or the resources to go outside of that. So I mention all these gaps because as a company, we want to help minimize some of these gaps or bridge some of these gaps. And that's what prompted us to give a name to this principle, and we're calling this principle the Mental Health 360. So anyone who's dealt with psychiatric patients before will probably know a lot about the patient's environment. Okay, they'll probably know a lot about the patient's lifestyle. They'll probably know a lot about the patient's experiences throughout their life, PTSD, personality disorders, all based on certain experiences that they'll have. Up until now, we haven't really had an important component of a patient's background, and that's their genetics. The best we could do up to this point was to say, hey, is there a family history of bipolar? Is there a family history of impulsivity? How did mom do on Prozac? How did dad do on Adderall? Now we can apply hard genetics to answer some of these questions and solve some of these problems. So the Mental Health 360 is designed to accomplish a couple of things. Number one, address that missing piece of the puzzle, genetics, not just for pharmacogenetics, but also to make assessments of certain genetic predispositions. And that's at the heart of the mental health map, which Dan will talk about soon. Another part of 360 is to treat patients along a continuum, along a spectrum, and not wait until they're at grade 3 or grade 4, like I mentioned earlier. So with this in mind, our goal is to develop a platform of services that address these gaps and contribute to this mental health 360 approach. Many of you probably think of us as a pharmacogenetic testing company, and there's no doubt that's what we do. That's most of what we do, but you may not be familiar with all the products and all the services that we offer. So here is a snapshot of everything that we offer. I imagine most of the people on this call are familiar with our pharmacogenetic test, which is called Genomind Professional PGx. The name kind of gives it away. That is our flagship product, our pharmacogenetic product. You need to be a licensed prescriber in order to order the Genomind pharmacogenetic test. I'll spend time talking about that later. It's a 24 gene panel, both pharmacokinetic and pharmacodynamic. With every one of those tests, you have access to GDIG, which is software that we built, custom software that we built in-house that is known as the Genomind Drug Interaction Guide. It marries drug-drug interactions to drug-gene interactions to drug environment interactions. One of the I'll steal someone else's term. One of the Achilles heels of pharmacogenetic testing is that it doesn't account for drug-drug interactions. Well, we saw that as a black eye for the field of pharmacogenetics. It's missing an important component. So we built software that incorporates not only your pharmacogenetic profile, but your drug-drug interaction profile into one platform. I'll show you that later. And I think I'll probably show everyone some of the enhancements we're making to this also. The new kid on the block, like Laura mentioned earlier, is the Genomind Mental Health Map. This is a direct-to-consumer offering. Okay, it is not a pharmacogenetic test. It will not tell you anything about Prozac, Adderall, Abilify, or Tegretol. It is a direct-to-consumer test. It's ordered by anyone. You can go to Amazon right now and order this. You don't have to be a licensed practitioner or a healthcare provider to order this because it tells you nothing about pharmaceuticals. What it does is make an assessment of your genetic predispositions for certain traits. That's all I'll say about it because I don't want to steal Dan's thunder here. We've also partnered with some really good companies to help bridge some of these mental health care gaps. Neuroflow, for example. We've partnered with Neuroflow. They have this really nice synchronized platform which helps with measurement-based care. So it can measure your patient's PHQ-9 or GAD-7 or Vanderbilt across a continuum and provide you with that information so that you know in real time whether your patient's anxiety scores are increasing or decreasing. We've also partnered with Albertsons, which is one of the country's largest grocery chains. They have several different banners. You may know them better as Save-Ons. Out in the West Coast, they're called Albertsons. I think they're called Jewel Osco up in the Chicago market. But Albertsons has pharmacies in most of their stores. In the Idaho market, in the Chicago market, in the Pennsylvania market, you can walk into any Albertsons pharmacy and order pharmacogenetic testing. So a patient could walk in, talk to the pharmacist. The pharmacist can say, well, you're taking a medication where there may be pharmacogenetic guidance associated with it. Are you interested? The pharmacist can connect with the doctor or the nurse practitioner, any prescriber, get an order for that pharmacogenetic test and get their results. Both the doctor, the nurse practitioner, and the pharmacist would have access to the report, and it creates a collaboration of care. So we're forming more of these pharmacy partnerships. Next, I want to talk about the differences between our flagship product, which is the pharmacogenetic test, and our newest product, which is Genomind Mental Health Map. So I hinted at this already. Everyone is probably familiar with the PGx test. You have to be a licensed prescriber to order it. It assesses genes that modulate pharmacokinetics. How well do you absorb medications? How well do you metabolize medications? How sensitive are you to some medications? What are your risk of side effects to some medications? I said the word medications 4 times there. This is your medication test, okay? Pharmaceuticals. Genomind mental health map, on the other hand, is an assessment of your mental health predispositions. You probably know people that are very impulsive. Well, there's a lifestyle component to that. There's a learned component to that, but there's also a genetic predisposition for that. You probably know people who have a very high startle reflex. That's mostly a genetic component and less of an environmental component. So Dan will spend time talking about these. These are the main differences and similarities between these 2 tests, okay? I've mentioned this a couple of times. So who can order each of these tests? The mental health map, anybody can order it. So if you want to go to Amazon right now and order that and get an assessment of your different trait predispositions, you could do that right now. You don't need to be a licensed healthcare professional. For the pharmacogenetic test, you do have to be a prescribing clinician. Genomind mental health map, again, assesses these predispositions, and it costs $599. And that is not billable to insurance plans. So that $599 is a direct cost to the patient. Now, you, as a healthcare provider, can get access to this test for a patient at a $150 discount from that $599 price. And we can talk more about the logistics of that later. But if a patient was to go, or an individual was to go to Amazon right now, the list price would be $599. For our pharmacogenetic test for Genomind Professional, most patients pay about $399 out of pocket. This test, GenPro, can get billed to insurance and does get billed to insurance. And most patients will still have about a $399 out of pocket cost. Okay. If you look at the bottom of your page right there, you'll see this sort of spectrum of symptoms. In some cases, it's not even symptoms. We'll call them subclinical traits, things that may affect your life, but not quite rise to the level of being a problematic symptom. We put this here to help identify what individuals are best suited for these different types of tests. The PGx test is better suited for those with moderate to severe symptoms, because those are the people who are more likely to need medications, whereas those with subclinical or very mild symptoms might be better suited for the mental health map. Their symptoms don't rise to the level of medication. For both tests are performed in-house in our lab. They are double tested. So we have 99.9% accuracy in our lab because we double test every sample. Turnaround time is still in the 3 to 5 day range for both tests. GenPro, the PGx test, we can get out the door a little bit quicker, but mental health map is usually back to the customer in about 5 days. And we offer consults for both of these tests. Many of you may have had our pharmacogenetic consult. That's mostly PharmDs and PhDs. For the mental health map, we've trained what we call advisors, and these are individuals who have different backgrounds. Some are nutritionists, some have a psychology background, and these are people who do our consults for the mental health map. Okay, so I think that's a good summary of all of our products, our services, an introduction to the mental health map. I'm now going to hand it over to Dan Van Dorn, affectionately known as DVD, and he's going to take it from here. All yours, Dan.
Thank you, Dr. Dow. Let me share my screen. I think I need to get permission, Laura. Okay, hold on.
All right, sorry about that.
All right, I'm bringing it up. Pay no attention to the man behind the screen. And everybody can see the screen right now. Is this right?
Yes.
Perfect. So thanks a lot for the introduction, Dan. So I'm actually really pleased to have this opportunity to introduce the Genomind mental health map along with the professional PGx test. This represents years of sweat, tears, dedicated work and research to offer these tools to improve the lives of patients and those who are not yet patients but are struggling with mental health issues. Now, both these tests are predicated on the Mental Health 360 model. And I know that Dr. Dowd has already mentioned this, but I think it's worthwhile bringing up again because this is so very important. This really lies at the crux of what drives our company, why we all come to work, either physically or virtually every day. It's really at the crux of the services we offer and the value that we offer to you and your patients, the tools that provides insight into your patient's predispositions and how they are likely to react to certain environmental cues. Now, whereas the Genomind Professional PGx test can inform you on how your patients are predisposed to react to certain drugs, to psychotropics, the Genomind Mental Health Map can inform you on how they got there to begin with, how they are predisposed to react to their environment, to social cues, to stressors, nutrients, and how that can cause them to struggle where others might thrive. Now, taken together, these two products offer the Genomind platform. It's a holistic platform that provides a tool for any patient, any individual at any point on their mental health journey. Now, I'm going to walk you through the process. I'm going to start at the 1,000-yard view and then hone in on the specific, one specific gene, and then offer some additional insights after that. Starting at the beginning, so what is it? It's basically just, it starts with a cheek swab. So your patient can do this at home in the privacy of their home. They can do this with both PGx as well as the mental health map, that you can have it shipped to their house, or in your office if you're currently seeing patients. It's very simple. You don't have to spit into a tube. You don't have to take blood. You ship it, and as Dan said, within 3 to 5 business days of receipt, the patient will receive the reports. And I'm using the term reports plural because the Genomind Mental Health Map actually is comprised of 7 distinct reports, 7 genetic reports that represent the core mental health capabilities. These are stress and anxiety, mood, focus and memory, habits and substance use, sleep, social behavior, and eating behavior. Now, these domains or these capabilities is predicated, as Dad mentioned earlier, it was influenced strongly by research domains criteria. So this is an initiative of the National Institute of Mental Health, which basically was developed to try to learn what drives human behavior. So basically tossing away DSM-5, which basically almost looks at basically mental health through a lens of pathology and subjectivity. So you're anxious if you feel, you have anxiety if you feel anxious, you're depressed if you have depression. So rather than this subjective term, which really propagates the idea that mental health issues and the pathology is just something that's internal, it's not caused by something physical, research domains criteria actually would set out to look at what is known, the neurobiology that drives human behavior from the full spectrum, not just pathophysiology, but from everything from the adaptive to maladaptive, the euthymic to dysthymic. And when you shift the picture, the conversation from pathology and DSM-5, it goes from what's wrong with you to what makes you unique, what makes you thrive in some situations or struggle in others. Another important theme of RDoC and what we've replicated in the mental health map is it ties together the physiology and how these domains they represent distinct clusters of behaviors or symptoms, but they have fuzzy borders. I mean, how often do you have a patient that comes into your clinic who just has depression or just anxiety? How often do you have a patient who comes in describing either themselves or a child swearing that they have ADHD and they need a stimulant, and upon further investigation, you're finding out that they're having issues with sleep or panic or anxiety? They may self-administer certain substances to try to deal with these issues. So the whole term MAP, mental health map, comes from the idea of learning more about the biological correlates that tie these domains together. And I'm going to touch on more on that in a minute. So first, I'd like to talk about the organization. So each report is further organized by traits. And you can think of these traits as subclusters of behaviors or symptoms that, again, are distinct, but they overlap, they influence each other. The three traits we discuss with stress and anxiety is our stress response, which is our visceral immediate response to stress, our fight or flight response, cortisol and adrenaline. Adaptability, which is how we adapt to certain situations. And then anxiety, which is how stress is expressed in our behavior over time, usually as a function of the other two. Now, our team at Genomind, through collaboration with world experts in the genetics of mental health, have curated a list of genes and single nucleotide polymorphisms, the variants that some of us inherit from our ancestors and others don't, that predispose us towards certain behaviors or traits that influence these subdomains. Now, I want to pause right here. So far, I've just covered the structure of the mental health map and how it's mimicking, to some extent, the research domains criteria model, but I really haven't shown you any value. And I'm going to admit here that if you have a patient who's struggling with anxiety, telling them that they're predisposed to worry, nervousness, or a heightened stress response isn't very valuable, right? They didn't need a genetic test to tell them that they're predisposed to anxiety if they're struggling with anxiety. So the first point here is that the value or the point of the mental health map is not to tell you who your patients are. It's not to tell you what you're struggling with. They likely already know this. Rather, when these predispositions that we call out, so what you're looking up at the screen right now is an example of a specific predisposition that some patient might receive for a heightened stress response. The value is understanding the mechanism, the biological mechanism that's driving this. In this case, in this example, it's stress hormone regulation, which is basically the two genes that we test for this mechanism is CRHR1 and FKBP5. Now, these gene names, unless you're very familiar with mental health genetics, just probably doesn't make a lot of sense to you. It's just a series of letters and numbers. But what these genes encode for, what they make, is the corticotropin releasing hormone receptor, which is the on switch for the fight or flight response, and this binding protein, which is actually the off switch. So you turn on the fight or flight response and then you switch it off. This individual we're calling out as having a variant in the FKBP5 gene, the off switch, that predisposes them to a heightened stress response. Now, I want to dive a little bit deeper with you on this and understand the biology involved here. So FKBP5 is this binding protein, and its job is to bind the glucocorticoid receptor. Glucocorticoid receptor is a nuclear receptor, which means that it has to translocate from the cytosol into the nucleus to do its job, to turn on certain genes and turn off others. Now, this is important because glucocorticoid receptor does many things in the body, but in the brain, its primary role is to turn off the fear response, the threat response, the HPA axis, that stress response. So in other words, once you get away from the lion, you don't want adrenaline and cortisol to flood through your body, so you want to turn that off. And FKBP5 is involved in that. And how it does this is very elegant. I think it's very beautiful. So essentially, when our ancestors, when they were out in the environment and they saw a lion, they would release stress hormones like cortisol in the brain and the body. And as cortisol would build up in the brain, it would kick FKBP5 off of the glucocorticoid receptor, which would free it up to translocate into the nucleus to turn off the fear response. So what you get is this nice allosteric curve. You get just enough of those stress hormones that you need to survive, and then you can turn it off. Now, here's the interesting thing. Individuals with this genotype, so this individual's FKBP5 genotype is T. So in other words, they inherited a T allele from both parents, from their mom and their dad. Most of us have a C allele. The T allele is less common, and it's actually associated with significantly increased expression of FKBP5. Now, for those of you who took OChem back in college, you probably recall this is basic saturation kinetics. With increased levels of this binding protein, it requires higher and higher levels of cortisol to kick it off. In other words, whenever someone does have a threat response and they have those elevated levels of cortisol, they have to really shoot up higher, in other words, to enable to turn that off, essentially. And we can see this in real time in what's called the Trier social stress test. So individuals would, when they see that they have this predisposition, they have the access to the new insights, new actions. And we tell them the story. We walk them through this process. It's a matter of validation and giving them a plan for improvement, evaluation, and empowerment to make changes in their life. And it starts with what's going on with you. What explains your experience? Why you're at this point in your mental health journey. And so we tell them the story. So the Trier social stress test is basically a well-replicated study where we know that individuals with this genotype, they have elevated cortisol levels when in response to stress. We know this because this is a study where they'll take healthy volunteers, usually college-age kids, I'm guessing because they're willing to do anything for a free lunch. And they put them in front of an audience and tell them to do something stressful, like give a speech to strangers. And then they measure their salivary cortisol. And individuals with this FKBP5 genotype, the elevated expression genotype, their cortisol levels go through the roof compared to those with the more common genotype. So what? What's the value here? Well, if this predisposition resonates with what they're struggling with, this provides some insight into what they can do about this. So in addition to many of the actions that you're going to take with them, maybe looking at a psychotropic if necessary, and other therapies that you'd want to approach and explore with them, you might want to consider targeting the stress response system with cortisol adaptogens, maybe focusing on grounding techniques, breathing exercises, cognitive behavioral therapies that help turn off this threat response, essentially. And as they begin to explore these, and I'm not going to go through each one of these now for the sake of time, but we can save time at the end. And of course, we can do one-on-ones if you contact your sales rep if you're interested. As they explore these, they can actually begin to validate their own experience, but also begin to explore their own symptoms. We give them access. You can see where it says how to measure. This is an insight that gives them access to the GAD-7, the PSQ-9, the pediatric symptom checklist. And so this is, it allows them to take these questionnaires completely anonymously. They can print it up and bring it to you to discuss their experience. And this idea, this platform that you see, this really represents the 4 pillars of the Genomind mental health map. This is every predisposition and all the insights and actions, everything that we want to bring to your patients is based on these 4 pillars. The first is validation. That, oh, it's not just in my head. There's actually a physical system that might be causing this, and it's real. It's not just in my head. The next is a plan for improvement. Now that we have this understanding with what might be driving these symptoms, we have some ideas of where to start to improve this. Evaluation, so we provide the screeners and questionnaires, not just on a mental health map, but also, as Dr. Dowd mentioned, through NeuroFlow, gives you access to those questionnaires that they're taking so you can track their progress over time and assign them grounding exercises and CBT exercises to improve. And then most importantly, empowerment. Having this empowers them, it gives them the vocabulary to have that very important conversation with you, their provider. And so that was really a quick introduction. I gave you one example of one predisposition on the Genomind mental health map. The mental health map actually represents 38 distinct variants, genetic variants that can result in 64 unique predispositions. Now, no patient would ever actually have a result that gave them all 64 predispositions, but you can have a handful. And so the question remains where to start. And we don't want to leave the patient saying, here's your results, good luck with that. We know through experience, in fact, this is replicated consistently, that when you just provide genetic results alone, it's meaningless to the patients. But when you provide genetic results plus education and coaching, that is so much more powerful than just the genetic results or the coaching alone. There's a great synergy there. So in addition to providing continued education to clinicians, because the idea is, as Dan mentioned, we very much believe in a collaborative approach. You, the clinician, you are the expert in diagnosis and treatment. We don't expect you to be experts in genetics. And so we offer you our cognitive services for both PGX as well as mental health map, so you can help to basically help you interpret these on behalf of your patients. For the mental health map, because this is a direct to consumer product, we offer that same process to the consumers themselves. Now, these advisors, so every mental health map comes with a 30-minute session with a brain trust advisor. Now, a brain trust advisor is not a therapist, it's not a psychiatrist. These are individuals, usually health coaches, who really just know how to walk your patients through the mental health map. So answer their questions, show them how to navigate that, and really tee up those questions or concerns that they can bring to you. So essentially, it's almost like we're teeing up the ball so you can knock it out of the park for your next session. Now, clinicians can join these consults. There's no HIPAA waiver required in that case. But honestly, we found that it's not really necessary. We're not really going to discuss anything significant to your treatment approach with them. It's really just walking them through the report. And you, of course, would have access to the full report as they share that with you. Now, I'm going to pause right here and just show you this. As Dan mentioned, this is our new baby that we just launched this year in July. And so far, the feedback has been amazing. And it's shown us that this has some power for those who are currently struggling with mental health issues, those who are in treatment, and how it synergizes with the approach of their therapists. And we also, collecting feedback, what you're looking at is the results of a survey that we sent out. And we had 30 respondents in this initial, broadcast of these surveys. But the results were really interesting because you can see, I've highlighted these, 70% of respondents reported that they would likely make lifestyle changes based on guidance provided in the mental health map. So again, what we're recommending oftentimes is no different than what you're already telling them. You tell them, hey, you should eat better. You should increase your intake of omega-3 fatty acids. You should exercise. And they say, yeah, sure, of course I will. Then you see him 2 weeks later, a month later, and you say, how's that going? It's like, well, I'm going to get around to it. But you'll see if you begin using this or the PGX in your practice, when they see why they should exercise, that it actually affects specific mechanisms in the brain that makes them sharper, increases their stress tolerance, suddenly that also increases their adherence as well. And of course, the last thing is that 83% of the respondents, now these patients, I'm sorry to say, these respondents weren't necessarily those who were being treated. These were early adopters, which oftentimes it wasn't just those who were being treated for a mental health issue. But still, 83% of them said that they would share the results with their provider to help them navigate the report and make changes in their life. And so I'm going to pause here. For the sake of time, I basically wanted to just give you an introduction to the mental health map. I'm going to now turn it over to Dr. Dowd. He'll go over the Genomind Professional PGx Express test. I'll stay on the line, and afterwards I'm happy to take some questions. And if we don't have time, if you're interested in the mental health map, reach out to your sales representative, reach out to us. They'll be happy to connect you with me. I'm happy to do a one-on-one with you. I actually hold bi-weekly meetings as well, which is an open forum, just to discuss mental health map and how you might use it in your practice. So Dan?
Thanks, Dan. While you still have the share screen, you want to just scroll to the next screen?
Sure. Do you want me to stop sharing, or do you want me to hit next step?
No, because I'm going to do a demo of GDig. So
right.
After that, then I'll take the screen back here. But so now we're going to move on to Genomind Professional PGx. We'll go over our tests, what's included in the pharmacogenetic tests, and then I'll highlight GDig for you. Next slide, please, Dan.
Mm-hmm.
So a little sort of 100-yard view of pharmacogenetic testing. And again, probably preaching to the choir here, but pharmacogenetic testing is specific for drug response. And it feels silly to have to say that, but there's still people out there who think our genetic test is designed to, diagnose you with bipolar or diagnose you with ADHD. And it does not do that. There is no test that can do that. But we can make assessments on how you metabolize the ADHD medications and your likelihood of skin reactions with certain medications or your likelihood of response to SSRIs. Okay, this is just another tool in the toolbox to go along with everything else that you're already doing. Again, probably don't need to say it to this crowd, but you should never make any decision based solely on a pharmacogenetic report. In fact, that's one of the criticisms of pharmacogenetics is that providers look at a test and they'll, make a decision based on a code on a pharmacogenetic test and ignore everything else. Now, No one on this call does that, but apparently there are providers that do that. So I feel it necessary to say that. Never rely solely on pharmacogenetic testing to make a decision. And though we do have genes on our tests that can make assessments on improved response to certain drugs, it still does a better job telling you what drugs not to use as opposed to what drugs to use. So it does a better job at making a drug tolerability assessment than to select the ideal drug, so to speak. We still can't flip over a card and say, hey, this is your perfect drug. We're not quite there yet. I do want to identify some of the major players in the field of pharmacogenetics. So the FDA, let's start with them, because you may not know that the FDA, in the FDA label itself, there are about 270 medications that have pharmacogenetic guidance, warnings, alerts, dosing recommendations right in the label itself. I'll give you an example. If you open up the Celexa drug label, it will say, if you are a 2C19 poor metabolizer, do not exceed 20 milligrams of Celexa. You can't get much clearer than that, right? And that's in the FDA label. A couple of other players in the field of pharmacogenetics. I want everyone to be familiar with CPIC, CPIC. This is the Clinical Pharmacogenetics Implementation Consortium, CPIC. These are a group of researchers from institutions around the country, actually around the world, that standardize the field of pharmacogenetics. All the terms we use within pharmacogenetics, normal metabolizer, intermediate metabolizer, star alleles, CPIC has standardized this. And they also have published guidelines, dosing guidelines and pharmacogenetic guidelines. These are peer-reviewed, they're open access. You all have access to the CPIC website right now. You can go there and look at all of their published pharmacogenetic guidelines. They have them for the SSRIs, they have them for the tricyclics, they have them for several of the mood stabilizers, they have them for several opioids. I was on the monthly CPIC meeting today. They happen to have it today, and they will very likely start working on a pharmacogenetic guideline for the antipsychotics, aripiprazole, risperidone, pimozide, maybe quetiapine, but there'll be probably 8 or 9 antipsychotics that have a pharmacogenetic guideline. In addition to CPIC, there is sort of a European equivalent to CPIC called the DPWG. That's the Dutch Pharmacogenetic Working Group. And then lastly, there is a fantastic database called PharmGKB, which lists drug-gene pairs, and it ranks those pairs by level of evidence. So I provide this information because one of our common requests is, where do I get more information? Where do I get more education about this? Well, you can spend all day, you can spend all week looking at PharmGKB and never see the same thing twice. It is a fantastic database. Keep in mind CPIC and DPWG. Hold that in the back of your cerebellum somewhere for a minute, because we're going to talk about that in a second. And last but not least, if you ever have questions about the data to support some of the claims on our tests, we maintain a white paper with every publication to support any of the claims on our tests. We're happy to send that out to whoever's interested. Dan, next slide, please. Okay, so this is our pharmacogenetic test in a nutshell. We look at both pharmacokinetic and pharmacodynamic genes. Pharmacokinetic just means a gene that influences blood levels. That's it, okay? And there's 2 ways we can influence blood levels. We could change your absorption of a drug, or we could change your metabolism of a drug. CYP450 enzymes, so CYP2D6, CYP2C19, these are all drug metabolism enzymes, and the different flavors of these enzymes are normal, intermediate, poor, rapid, or ultra rapid. So there's sort of a bell curve of phenotypes. In addition to these metabolism genes, we also look at genes that affect drug absorption. How efficiently do these drugs get into our blood? how efficiently do these drugs get into our brain, blood-brain barrier penetration. So that's PK. We also look at pharmacodynamic genes, genes associated with sensitivity to drugs that doesn't necessarily have to do with blood levels. So your risk of waking with certain antipsychotics, there's 2 genes associated with that. Your odds of response to methylphenidate, 2 genes associated with that. Your risk of skin reactions with carbamazepine, oxcarbazepine, or lamictal, there's 2 genes for that. So these are your pharmacodynamic genes. Pharmacodynamic are receptors, ion channels, other proteins that affect your sensitivity to a drug. Pharmacokinetic is how much of the drug is in your body or in your brain. So these are our different genes compiled by the different drugs they affect and the different categories of treatment that they affect. So the first cluster that you see there are genes that affect depression or anxiety treatment. Some of the specific groups of drugs are SSRIs, SNRIs, or augmentation with methylfolate. We have a cluster of genes related to mood instability and psychosis treatments. So the usual suspects there are your antipsychotics and your mood stabilizers. We have a couple of genes related to weight gain risk with the 2nd-gen antipsychotics. A couple of genes related to ADHD treatment. A couple of genes related to opioid sensitivity. A couple of genes related to alcohol abuse treatment. I know when we think drug abuse, the knee-jerk reaction is to think opioid abuse, but there's probably 4 to 5 times as many people suffering from alcohol abuse as there are opioid abuse. And there's 2 genes related to response to things like naltrexone or Topamax for alcohol abuse. And then lastly, 2 genes related to your risk of skin reactions with mood stabilizers. Okay, and I don't mean acne with the mood stabilizers. I mean life-threatening skin reactions, Stevens-Johnson, toxic epidermal necrolysis, etc. So now I want to take time here to talk about some of these pharmacokinetic genes. Dan, if you stop sharing right now, I'm going to try to share GDIG here.
Yeah. And although we quickly segued from the pharmacodynamic genes, you're going to give everyone an option to explore this on their own, to choose their own adventure where they get the
That's right.
On what we're going to explore together. So we're sort of taking a segue into the pharmacokinetics because this is a really interesting tool that can help you navigate that, but then we can have some fun with the pharmacodynamics as well.
Yep, we will come back to pharmacodynamic. First, I want to show you GDIG because this is our tool, our software that we built that assesses these very complicated pharmacokinetic interactions. So the name of the tool is GDIG. So I probably shouldn't do this because what I'm about to show you is still, we're still working on this. This is we're making enhancements to GDIG, and you were the first group of people to see this. So I probably shouldn't show you, but I'm going to show you anyway.
Can you get an
Laura,
NDA
can you
from everyone?
Yeah, can you get a waiver from everyone, Laura, while we're doing this? So you'll see that this tool, this software, allows you to test drive different medications that you're considering. Okay, so I'm going to plug in here. Oh, it looks like I timed out. All right, let me refresh. All right, so now that I'm refreshed, I'm going to adjust this person's genetic profile. You would never have to do this. This genetic profile would already be present, but everyone who does a pharmacogenetic test has access to GDIG right now. So if I were to add a medication like Lexapro, and I'm going to actually change this person to a 2C19 poor metabolizer. So here we have Lexapro. You see that we have an up arrow here, which means increase in serum levels. And we also have a risk assessment. So the different levels of risk are, high, moderate, or low risk. Higher risk usually means based on this person's genetics or based on a drug-drug interaction, we can expect at least a 2-fold increase in serum levels of this particular medication. So with Lexapro, because this person is a 2C19 poor metabolizer, it's a pretty significant interaction when it comes to Lexapro. You'll also notice this little notepad icon. That tells you that there is a specific pharmacogenetic guideline available for this drug. So this is the part I'm not supposed to show you, but we have very shortly, you will be able to view any available pharmacogenetic guidelines by clicking on this PGX guidance section right here. And if we do that, the system is smart enough to know this person's genetic profile and then provide you with every agency that has a pharmacogenetic guideline. So the CPIC guideline, the recommendation is consider a 50% reduction in the starting dose or select an alternative not metabolized by 2C19. Okay. The FDA has a comment on escitalopram in the label. It says a 20 milligram dose is equivalent to 30 milligrams in a poor metabolizer. So now you've gotten some more information. DPWG has a very similar dosing guideline, 50% of the standard dose. Okay. All of these links are live. So if you were to click the CPIC guideline, it would bring you to the actual peer-reviewed published guideline. Let's dig a little deeper into the CPIC guideline right here. So it says consider a 50% reduction in dose. Okay, easy enough. Or select an alternative not metabolized by 2C19. All right, off the top of your head, can you name all the antidepressants not metabolized by 2C19? I can, Dan can, because we do this for a living. But if you cannot, you can look at alternative medications to Lexapro, and it will rank them based on their pharmacogenetic status. So citalopram has the same problem that escitalopram does. Sertraline, similar problem, although it's a lower risk. How about fluoxetine, fluvoxamine, or paroxetine? Fluoxetine actually looks pretty good. So we'll just replace the old drug with the new drug. Now you have minimized gene-drug interactions for this patient. If you wanted to stay with Lexapro, that's fine. The recommendation is to use 50% of your standard starting dose. Another example here, if we were to enter Tegretol, we can see that this person happens to be HLA-B positive and that they have an increased risk of skin reactions. What is the official guidance on this? Well, this is easy. Don't use it, all right? CPIC says don't use it. The FDA says don't use it. DPWG actually doesn't have a guideline, but the risk of skin reactions is about 100-fold higher in this individual. So let's not use Tegretol. There's probably better alternatives here. Okay. One of the last features I want to show you, I'm going to edit this person's genetic profile here just a minute. I'm going to add Zyprexa into the profile, and Zyprexa looks pretty good. But what about in smokers? We know that smoking can influence serum levels of some medications. And that's exactly what happens with Zyprexa. This person has a particular genetic variant that is extremely sensitive to smoking. And so if this person smokes, we expect an even more dramatic decrease in Zyprexa levels. Okay, so that is a very quick and dirty version of GDIG. If you're interested in learning more about this, I'm happy to go over this in detail with anyone who's on the call. But I just wanted to show this to you because this is available to you right now, and you probably don't even know it. So only about 20% of our clinicians use GDIG at this point. Only about a third of them even know it exists. You all have access to this if you've run a genetic test with us. So those new enhancements that I talked about, they should be live early next year, but it's still a pretty good product without those enhancements.
I mean, right now you still get the interaction, drug-drug interactions. They tell you that there's increased exposure. The only thing that's lacking right now, Dan, is what? The alternatives.
Exactly. So you don't have that alternative drug list right now. You also don't have the specific guidelines. but you will shortly. So probably in a few months.
But I think the point is we want to highly encourage you to use that, because even in its current state, it can still be a very valuable tool in selection.
All right, so that was GDig. Now I think this is where we're going to do our choose your own adventure. So going back to some of our pharmacodynamic genes, here's all of them. We certainly don't have time to go through all of them, but Laura, can you launch the poll right now? So we're going to do choose your own adventure. Everybody take a look at the polling question and let me know if you want to talk about genes associated with antidepressant response, genes associated with weight gain risk with the antipsychotics, genes associated with the adverse skin reactions, MTHFR, ADHD response genes, or alcohol abuse treatment response genes. So please still make your selection now. And we'll see if this comes in how we expect it to here, Dan.
Well, actually, while we're waiting, I just had someone for the next poll. Someone suggested a grown-up Charlie Brown.
That's perfect. All right, I'm going to adjust that. Was that someone internal, Dan?
I don't recognize it. So, I mean, I've actually used Charlie Brown as my avatar. So that's fitting, I suppose.
That's perfect. We need to find a Lucy now. How are we doing with the poll, Laura?
Grown up Charlie Brown.
Didn't Netflix or somebody just buy the rights to Charlie Brown?
Oh, I haven't heard. I mean, that's a classic, especially this time of year.
Yeah. All right, Laura, any results in? All right, so this, pretty much what we usually get, the SSRI, SNRI response genes, so we'll certainly take a look at those. And number 2 on the list, ADHD response genes with MTHFR are a close third. So, all right, exactly what we usually see. So let's jump right into SLC 6A4. This is like the Brad Pitt of pharmacogenes, because most testing panels have this. Most people are familiar with the serotonin transporter. Let's dig a little bit into the details behind this gene. So SLC 6A4 is the gene that makes the serotonin pumps, also known as the serotonin transporters. These little yellow blocks right here are a representation of your transporters or your pumps. They're the vacuums that suck up synaptic serotonin. Now, this gene comes 2 different flavors, really 3 different flavors, but let's talk about 2 of them for now. You can have a long version of the gene or a short version of the gene. The short version is literally shorter. It's 44 base pairs are missing from the promoter region, so it's literally a shorter gene. Now, the short gene makes fewer serotonin pumps than the long gene, okay? And you can imagine there's 3 different combinations here. Individuals exist as long, as long short, or as short short. Those are your 3 phenotypes. Long longs make the most serotonin pumps. Long shorts make intermediate amounts of pumps, and short shorts make the fewest serotonin pumps. Comparing a long to a short shorts make about 50% fewer serotonin pumps. So think about this for a second. If you're long, you have plenty of these pumps. You can vacuum up serotonin pretty efficiently from the synapse. If you're short, you have fewer pumps. You don't vacuum up serotonin as efficiently. These are people who tend to have higher synaptic serotonin. It's almost like they're born on an SSRI. Okay, they don't clear serotonin as efficiently. So now, take that same person, take that short individual, and give them an SSRI, whichever one you like. You're essentially flooding the system with serotonin at that point. Not surprisingly, people with the short genotype are more likely to have side effects from an SSRI. Mostly that includes gastrointestinal side effects, nausea, vomiting, diarrhea. but it also includes insomnia, activation, irritability, sexual dysfunction. It's not as clear whether SLC6A4 is associated with that, but certainly GI side effects, activation, and insomnia is more common in the shorts or the short carriers. And that very likely is the reason why there's a difference in response rate and remission rates if you compare long to short. The difference between the two is about 60%. So you're about 60% less likely to respond to an SSRI if you have the short genotype compared to the long or the long-short genotype. Okay. Now, remember I said there were 3 flavors of this gene? Well, I didn't mention the LG variant right here. So there is a long gene and a short gene, but there are 2 types of long gene. The normal one is called LA. It's long with an A base pair where it should be. Some of us have a long gene with a G base pair. It's a point substitution. A single base pair has been substituted, a G for an A. When you have the LG variant, it's equivalent to a short gene. So whenever you see LG, just convert that in your brain to short. It means the same as short. Physiologically, it works the same way a short gene does. So LG means the same as short. Higher likelihood of adverse events and poorer risk of poorer response to the SSRIs. All right, so that's the serotonin transporter. We'll also talk about another gene associated with antidepressant response. In this case, it's the Bdnf gene. Okay, BDNF is, we could talk an hour just on BDNF. It tells us a bunch of different things. We're going to talk about it in the context of antidepressant response right here. BDNF is brain-derived neurotropic factor. It is your brain's miracle grow. It's a protein that literally enhances the connections between your neurons. It increases the density of the connections. It increases the length of the dendritic spines. It makes your connections nice, tight, linear. It's good. Now, some of us secrete BDNF at different rates or different proportions, and the people who carry the MET allele tend to have lower dependent secretion of BDNF. Okay, I'm one of those people. I'm a BDNF val-MET, so I undersecrete BDNF. One of the things that's associated with is a better response to exercise, which sounds bizarre, but some people have greater improvements in cognition and greater improvements in mood symptoms with exercise compared to those without this genotype. So we're not saying that you need a genetic test to exercise. What we're saying is everyone improves with exercise, but the BDNF MET carriers have a greater improvement. The slope of that line is steeper than those without that genotype. Going back to antidepressants right here, here's a study looking at 2 different ethnic groups. On the left is a meta-analysis looking at Asian patients. On the right is a large study in Caucasian patients. This was a French study, so they were all French patients. Let's start with the meta-analysis on the left. It included about 600 Asian patients, and it looked at response to SSRIs based on BDNF genotype. And you can see that the odds ratio here was about 74%. So MET carriers were about 74% more likely to respond to an SSRI in Asians. That's East Asians, Chinese, Japanese, Koreans. If you've ever seen our report, you'll notice that we make ethnic specific claims on our report. So we'll say things like, if this person was BDNF positive, we'll say improved likelihood of response to SSRIs in East Asians. Now, in Caucasians, it's a bit of a different story, and we're not entirely sure why ethnicity plays a role here, but in Caucasians, it was shown that those who carried the MET allele, people like myself, had a higher remission rate to SNRIs or tricyclic antidepressants. The medications included in this study were Effexor, Cymbalta, Imipramine. Those are the three main ones, SNRIs and tricyclics. And those who are Val-Met, like myself, are the green bar right here. Okay, remission rates were greater than twofold higher in the Val-Mets for the SNRIs or tricyclics, but they were about half as impressive for the SSRIs. So you see different outcomes based on ethnicity and based on this Bdnf genotype. So those are the two main genes we look at when it comes to SSRI, SNRI response. The last category here was ADHD treatment response. And there's really two genes. Well, that's not true. There's three genes associated with your ADHD drugs. One of them is the 2D6 pathway, the drug metabolism pathway, CYP2D6, because all of your amphetamines go through the 2D6 pathway. From a pharmacodynamic standpoint, it's Compt and Adhd that impact your response to stimulants. Let's start with Adhd. This is a norepinephrine receptor, and a meta-analysis
I faxed over the last few
Adhd.
patients. Anything
Hey, can
else I
everybody
can
mute
do before you
themselves,
go?
please?
No, I'll be here for a little while, but 8 o'clock confirmed.
Hey, Laura, I'm going to need you to mute everybody, okay?
Waterman.
So if we look at a
Samantha,
meta-analysis of those who had the Adhd, those with the G allele tended to have better response to methylphenidate, and to the tune of about a 70% increased odds of response in G allele carriers. Okay, so if you don't have the G allele, that's bad news for methylphenidate. These are kids where you might want to consider the amphetamines as a first-line treatment. All things being equal, of course, you might want to consider the amphetamines as opposed to methylphenidate as your first-line treatment. The last pharmacodynamic gene we'll talk about here is this Compt gene. Now, Compt there's a lot to unpack with the Compt genotype also, but for the interest of time, we'll focus on Val-Val versus Met-Met, specific for stimulant response. Compt has to do with how much dopamine is available in the frontal cortex, because Compt is the primary enzyme to clear dopamine in the frontal cortex. Val-Vals tend to have lower dopamine. Met-Mets tend to have higher dopamine. I'm a Val-Val, so if you were to, cut open my frontal lobes and look at all the dopamine in there, I would have less of it than, probably most people on this meeting. If you were a mad scientist and you were going to develop a medication for a Val-Val, you would develop something to boost dopamine. Well, that's what your stimulants do. It's what methylphenidate does. It's what amphetamines do. To some extent, it's what bupropion does. Val-Vals tend to have better response rates to your stimulants. Okay, there's one study that came out last year showing that Val-Vals actually did better on bupropion also. So Val-Vals tend to do better on dopamine enhancers. And the mechanism is that these people are genetically born with lower dopamine levels. So there's a sort of an upside down curve when it comes to dopamine. Val-Vals tend to be on the lower end of that curve. With stimulant use or dopaminergic enhancers, you can push them up to a more optimal level. Okay, so that's the mechanism behind Compt and response to some of these ADHD medications. And for the interest of time, I think we'll start wrapping things up here, but we can answer more questions. Let me run to the end of my slide here. The last thing I'll talk about is sort of the golden rules of pharmacokinetics while we do questions and answers. Actually, let me hand it off to, let me hand it back to Laura here. She can answer some of the logistical FAQs, but I think, everyone's probably tired of listening to me and Dan. So Laura, we'll hand it back to you. You can go through the logistical stuff and then we'll open it up for questions.
Sounds great. Thanks. So So we've got just a couple of FAQs on, pricing and ordering, which I know we've covered a little bit of this in the chat, but I just wanted to provide a refresher. And then also we will be sending a copy of the PowerPoint and a link to the recording in the emails that you'll receive from your sales rep tomorrow morning. So if you've missed some of this, it'll be all in the email. So the MSRP, the full retail price of the new Genomind mental health map is $599. So if you go to Amazon, that's the price that you'll likely pay. However, we are offering a professional discount program to all of our clinicians at 25% off all year round. So that brings the price down to $449. In order to receive that discount, you'll need to order and receive a professional discount code through your sales rep, and it'll be your prerogative to how you want to price that test out to your patients. You can price it at $599, or you can give them the discounted price. That's your choice. We provide free shipping both to you and back to our lab. We can also provide some patient brochures for your office and any kind of collateral that you may need. And of course, Dr. Van Dorn indicated that he provides a bi-weekly training program, which you can also receive a link to from your salesperson. And then we're happy to do any kind of educational training that you might need for yourself and your staff. Next slide is going to cover, I believe, the Genomind Professional PGx pricing and information. If you could advance for me, please, Dan. There you go. Oh, one more. So as I mentioned, the mental, okay. Follow the bouncing ball. So PGx, so the prescription product that I believe most of you are familiar with is Genomind Professional PGx Express. We've added some advanced services this year as a result of COVID. So now you can order online the test and have it shipped directly to your patient. FedEx, and it will also be picked up by FedEx at Genomind's expense. So that is available through the online portal, our ship to patient offering. You can still have patients tested in your office if you have office hours open. The choice is yours. We have the on-demand consults, which are provided by both of these gentlemen tonight, our PhD and PharmD MSL team. And you can schedule those ideally through the clinician portal, or you can call our customer service team and they'd be happy to help accommodate a setup of the consult. It's also available if you want to have your patient or a caretaker on the call. Just as long as you're on that call with us, we're happy to have your patients be involved. Dan walked us through the GDIG tool, and you all got a sneak peek of the new enhancements. We're really excited to roll that out in Q1 2021. I think I covered the pickup and delivery. We also mentioned at the top of the call that we have the fastest turnaround time in the industry, which is really less than 3 business days. And of course, that's due to FedEx to and from your offices. And then also NeuroFlow is a wonderful electronic remote patient monitoring platform. We'd love to tell you more about that if you're interested. And then finally on pricing, so Genomind Professional PGx is billable to insurance. If you'll advance a slide for me, please, Dan. Perfect. We bill and accept all commercial plans, all flavors, HMO, PPO, et cetera, and Medicare Advantage plans. So those patients will typically pay $399 out of pocket. We have gone to an online prepayment method, which I think patients are excited and relieved to know what their cost is going to be right up front. There's no mystery bill coming down the road 3 or 6 months later when their insurance finally processes and adjudicates the bill. Makes everything very easy, no surprises. We highly recommend that you speak to your patients or make them aware that their HSA or FSA could cover 100% of the cost of the test. For Medicare, participating Medicaid states, managed Medicaid, and TRICARE, those patients will have zero out-of-pocket responsibility. We do offer a self-pay price if you choose to go around your insurance for whatever reason, or if you don't have insurance, the full self-pay cost is $2,000. And we do offer flexible payment plans that offer a monthly payment plan year-round at no cost, no surcharge, no interest. And we do offer a prompt pay discount. If you want to pay that upfront, we'll give you a 15% off discount. And then, of course, we mentioned HSA and FSA plans cover the full cost of the test if you have those programs. Excuse me. Back to you, Dan, I believe.
Yeah, so we're pretty much done here. Just to kind of summarize things, we are happy to be your sort of personalized medicine partner. So for all of these platforms of services, we will provide you with top tier consultation, any education you want, any access to literature, interpretation with any of our reports or our products. We have a medical affairs team of about 7 at this point, which includes PharmDs and PhDs. Each one of them is excellent. And so if you can't catch me and Dan, 2 of them happen to be on the call tonight. So Dr. Tori Hoffman, our PharmD in San Diego, Dr. Gabriella Williams, our PharmD in Indianapolis. They're both on the call tonight. Somebody will be able to answer your question or provide you with a virtual in-service or tell you more about our products. So we're happy to do that. We pride ourselves in education. So by all means, fire away. Thank you. Laura, I guess we'll do some Q&A, not for too long because it is 11 o'clock on the East Coast, but we're happy to do a little bit of Q&A right now.
Absolutely. So I know there's been some questions in the email about who is my rep and how to contact us. I'm just going to quickly give you our main phone number and we can direct you at that time. So Genomind's main phone number is 877, and Vanya, if you could put this in the chat while I'm talking, that'd be great. 877-895-8658. You can certainly go to our website, genomind.com, and you have access to our, contact us button on there, or send us an email, info@genomind.com. If you were invited to this event, that is more than likely your salesperson, but if you came with a colleague, we're happy to get you in touch with someone that can give you more information. And I think, Dan, that we covered most of the clinical questions. I think I answered the pricing questions when I went through the Q&A at the end. If I haven't answered your question, please pop it in the chat right now. We'd be happy to.
There was some questions around NeuroFlow, which is actually very interesting. We didn't prepare anything tonight for NeuroFlow. That's something that maybe we'll keep in mind for future, but I believe, Vanya, as you called out, when we send out this deck tomorrow, we'll send out information and you can actually reach out to your sales rep and they'll be happy to walk you through that process as well. Like GDIG, that can be a very valuable tool in following your patients and following the progress.
If you have any questions regarding the prior auth process, to be honest, it's unique for every insurance plan. Genomind is working diligently with different, Medicaid MCOs and different health insurance companies to facilitate that process, either through Cover My Test, which is a third-party prior auth program that we're partnered with, or with our own billing team. We have access to the prior auth forms that we can get to you from your salesperson. We really do want to make that process easy for you and for your patients so that we can get the test prior auth approved and covered and everyone can be happy with the result.
Hey, Dan and DVD, great presentation, you guys. So I received a question that I cannot answer, so I'm going to answer for you guys. Is the testing able to pick risk for adverse skin reactions to SSRIs or only mood stabilizers?
Right now, it is only the mood stabilizers. So in particular, it is carbamazepine, oxcarbazepine, and phenytoin, which is sort of outside of our scope, and lamotrigine. So having a positive HLA-B gene increases your risk of carbamazepine anywhere from 10-fold to 100-fold. It increases your risk of Stevens-Johnson's with lamotrigine anywhere from 2 to 4-fold. So it's only those 4 drugs right now: carbamazepine, oxcarb, phenytoin, lamotrigine, not SSRIs.
The common skin reactions, I mean, I don't mean to call them common, but the ones that you will see when you see them is through a different mechanism. It's not necessarily driven through the same autoimmune reaction that drives the Stevens-Johnson syndrome you see with those with carbamazepine. There was one question, Dr. Wong, you asked a really good one, which I've had these types of discussions in the past. It's regarding the stress sensitivity phenotype associated with SLC6A4 short. And that's something that we could spend a lot of time talking about, but I did see that you're also interested in the biweekly discussion, and I think maybe we'll kick it to that. But in short, forgive the pun, those with a short, they tend to have elevated levels of elevated serotonergic tone in certain areas of the brain, including the amygdala, interestingly enough, which is the primary fear center. And so those who have the short, they do tend to have this phenotype where they can be more sensitive to stress. It's almost like the orchid versus dandelion story. Interestingly enough, when it comes to genetics, when you're not talking about risks of certain drugs, these inherited variants that we got from our ancestors, it's not like some people have good genes and others have bad genes. That's not really how it works. Rather, our variants predispose us to thrive in some situations or struggle in others. And those with a short, they seem to be more sensitive to their environment, and that includes both the good and the bad. When these individuals are raised in an enriching environment, there's data that suggests that they actually thrive, that they do very well. Whereas though when they're raised in a poor environment, that's when they struggle. And the opposite would be true for those who have the long, they tend to be more resistant to the influences of either environment. Now, I hope that's not too dissatisfying an answer. And of course, I look forward to future conversations. We can dive deeper into that.
Thanks, Dan. By the way, in the chat box, you may have noticed I've entered a couple of links, some SurveyMonkey links. We would love for everyone to provide some feedback on the speakers tonight, including myself and Dr. Van Dorn / Charlie Brown. So,
well, there was some comment that we should probably do voices because it was implied that you sound like Chuck Schumer.
I did see that, yes.